Hi, welcome back to MSK2 and talking about upper cervical spine disorders. We've already covered the non-radicular pain on Marcy's lecture, as well as differential diagnosis of cervicogenic headache. So now we're going to go into some radicular symptoms as well as some viscerogenic and vasculogenic symptoms. So I hope this is an interesting lecture for you. It always is one of my favorites and things that I like to talk about. So we're going to talk about musculoskeletal origin. We already talked about the non-radicular pain and the patterns of pain. And now we're going to talk about radicular symptoms, such as occipital neuralgia. So as many neuralgia, we can have this either happen as a dull ache or a sharp shooting pain into the head. Also, some patients will say my head goes numb when I lay, on too hard of a surface, and that's usually some compression of the greater occipital nerve. There's a high area of convergence at the trigeminal cervical nucleus where a piece of the trigeminal nerve comes into the cervical spine. We'll cover that more when we talk about TMJ problems. So it's primarily a local entrapment, but we can have secondary occipital neuralgia due to tumor, trauma, disease, infection, osteoarthritis, so on and so forth. Remember that when your patient has a virus, that they can often have some increased laxity in the ligamentous support and may get a neck ache or a headache due to their infection. And it's a good resource for you for a tumor. Okay, now let's talk about vasculogenic origin of pain, where we can have actually problems with the internal carotid artery or the vertebral artery as a generator of pain in the cervical spine. So this can be due to underlying pathologies such as atherosclerosis. This can be due to diabetes, high cholesterol, high triglycerides, or problems with clotting. Trauma to the internal carotid artery can happen in a variety of ways. You can have innocuous dissection due to bending over the bowl at a hairdresser or backing up the car. So quick rotational movements on a neck that perhaps is just a little bit hypermobile. You can have intimal trauma of intima of the either of the blood vessels with extreme neck movements, such as football players who get face masks, boxing, actually even medical interventions like intubation, or sometimes high velocity, low amplitude thrust techniques at the upper cervical spine. There can be atherosclerosis or inflammatory events. You can have a disease such as temporal arteritis, which has been associated with internal carotid artery and vertebral artery diseases. And then upper cervical instability has been associated with localized atherosclerotic changes. So in particular, we can have microtraumas with our patients who have rheumatoid arthritis and Down syndrome. So remember that they tend to have laxity in the upper cervical spine, and if those patients are involved in acute whiplash injury, you need to be aware of instability issues with those patients. So the current recommendation is that you should have a high degree of suspicion of cervical arterial disease with patients who have a history of cardiovascular disease, a history of micro or macro trauma, or that have risk factors for upper cervical instability, such as rheumatoid arthritis or Down syndrome, or people that have had a recent car accident. So we, as with most things, we don't rely on one factor to build a hypothesis, but we use a cluster of signs and symptoms to generate our hypothesis. So to help you with your recognition of cervical artery dysfunction, the symptoms are just be aware of the pain pattern. We'll come up and show you that here in just a little bit. A history of trauma and a new headache like no other, especially those patients who are age 70 and older. The onset of a new headache is always cause for suspicion. And the other thing that you need to think about is measuring your blood pressure of your patients who are coming in with headache, also with diabetic issues. Okay, so in the objective examination, measure their blood pressure, do a cranial nerve exam, because ischemia around the cranial nerve can give you cranial nerve signs. You can do an eye exam, which is part of the cranial nerve exam. Those patients may be referred for Doppler and referred back to their physician. And then you have to be aware of the effect of neck movements on the vertebral artery. So this is the functional vertebral artery testing. This was adopted by the International Federation of Manual Physical Therapists, and they follow the Australian physiotherapy guidelines, which recommend a minimum 10-second hold in rotation. You'll watch the eyes for nystagmus, pupillary changes. You'll have the patient count out loud, backwards from a number to watch cognition, any dysphagia, or change in intonation of their voice. You can also do sustained pre-manipulative positional testing. So if you're getting the patient in a certain position of stretching or movement that you're not sure of, you can put them in that position and do the same test, holding it for a certain amount of time. There are documented different combinations of extensions and rotations of the cervical spine, but at times it's felt like the testing has been more of a risk factor for the patient than the actual problem. So does vertebral artery testing actually alter the blood flow of the brain so that we can see if the patient has enough anastomotic circulation to make up for the loss? Well, yes, it does. If we rotate the patient to the right, we get a decrease in the blood flow of the vertebral artery on the left side. The test is valid, but it has poor and variable specificity, so we can't either rule the condition in or out, where we feel like if we put the patient in a certain position, it's going to alter blood flow enough to their brain to cause problems. So the vertebral artery test is not particularly helpful. So some sources suggest that we use a cluster of signs and symptoms to build a case for the cervical arterial dysfunction and avoid placing too much emphasis on the vertebral artery test. So we might avoid testing when we already have a strong suspicion that cervical artery dysfunction is present. So just like we talked about, what are those? Patients with cardiovascular disease, hypertension, high cholesterol, high triglycerides, diabetes, genetic clotting factors, suspicion of hypermobility, or micro or macro trauma. So we want to assess for the safety of mobilization and manipulation techniques. So here's a picture of the vertebral artery and the internal carotid artery with the atlas in right rotation. So here the vertebral artery is coming in through the transverse foramen, doing a 90-degree turn and a sharp turn, another sharp turn. Remember, we're lying in the superior gutter, and then back up into the foramen magnum. So that's a lot of torque on the vertebral artery. And the carotid artery can actually be affected by osteophytes anywhere along the course. So if our patient gets in a position where they're not getting enough blood flow to the brain during one of our stretches or maneuvers, these are some of the things that can happen with the 5 Ds, the 3 Ns, and the 1A. So this is why we want our patients to be talking with us, so that we can hear their voices. We wanted them to tell us if they have any numbness, if they don't feel well, if we're going to watch their eyes in case they develop nystagmus. So this is when the patient is not getting enough blood flow to the brain and cranial nerve starts to become ischemic. But there are also non-ischemic vertebral artery signs and symptoms, such as ipsilateral posterior neck pain and occipital headaches. And what we have to remember is that non-ischemic symptoms can precede ischemic events by only a few days. So the patient has pain generated by the vertebral artery or the internal carotid, and what we want to be careful of is that there's not clot formation or a dissecting aneurysm going on in one of those vessels that's going to lead the patient to having a stroke. And this is the pain pattern. So you can see it's unilateral. It covers a fairly broad area from midline to the most lateral aspect and right to the occiput, coming down to about T2. So the internal carotid artery makes up 80% of the flow of the blood, and it bifurcates from the common carotid artery at the level of C3. And it's influenced by cervical movement, mostly by extension. So when we were doing vertebral artery testing in the past, we do a combination of extension and rotation. And I think that we were probably creating some stress to this tissue, and other people in the profession felt that way too. So this is what the internal carotid artery looks like in a non-ischemic symptom. So we have everything the vertebral artery had, and we have temporal headache. So this is another pain pattern that you want to be able to recognize. So in summary, talking about cervical arterial dysfunction, we want to have a high degree of suspicion when we have risk factors. And then recognize the pain patterns of cervical artery dysfunction. Be suspicious of all headaches that are like no other. And be aware that the vertebral artery test in and of itself, if it is negative, does not tell us that we don't have problems in that area. So please add blood pressure monitoring, cranial nerve testing, or a simple eye exam to supplement your objective tests so that we have a cluster of signs and symptoms. And these are your references. These Roger Carey and Alan Taylor write extensively about upper cervical problems. And this is the recommendation of the IFOMT for potential of cervical artery dysfunction. So we can have vascular problems with migraine, cluster, and tension headache. We covered cervicogenic headache already. I'm going to flip through these quickly. So these should all look very familiar to you. Be familiar with all of the pain patterns. And this talks more about Larry. Other causes of upper cervical problems. Whiplash-associated disorders is enough for a week seminar alone. These are the questions that you want to ask. Were the airbags deployed? Side bags and front bags? Did the patient have pain on impact, which can be a problem with structural damage? And then you need to clear for fracture and instability, which can show up as extreme upper cervical muscle guarding, so global restriction of movement with less than 50% of rotations available, and palpation will show midline tenderness. So we can have cervical trauma with AO dislocations, fractures of posterior arch of atlas, and rupture of the transverse ligaments, Jefferson fracture. This is what you do not want to have. And there's multiple pictures of these on the web. So thanks you guys for your patience. Welcome any feedback, and hope this helps your understanding of upper cervical dysfunction.